Panelist or member of the HQO staff will provide a response. Due to the large number of participants, we are unable to implement the Raise Your Hand feature during today's webinar. Any unanswered questions will be followed up with an email. You'll hear a number of voices on the line today. From Health Quality Ontario, you'll hear from me. You'll also hear from Stacey Barzeev, our team lead, and Jennifer Ray, Quality Improvement Specialist. Most importantly, you'll hear from our guest panelist, Chris Archer, Project Manager, North Simcoe HealthLink, Tracy Coble, Registered Nurse, Clinical System Navigator, North Simcoe HealthLink, Ann Mackay, Project Manager, East Mississauga HealthLink, Gwen Young-Wakor, Care Coordinator, Mississauga Halton CCAC, Robin Griller, Director, Mideast Toronto HealthLink, Mary Wheelwright, Director, Health System Integration, Headwaters Healthcare Centre, and Sharon Howlett, Provincial Lead, HealthLinks and Telemedicine Nursing, Ontario Telemedicine Network. We extend a warm welcome to our guest panel and will formally introduce our guests individually ahead of their presentations. As in previous webinars in this series, we'll provide you with successful practices, processes, and learnings related to the care conference phase of the coordinated care planning process. We identified innovative practices and lessons learned through a broad scan of the practices and processes happening in HealthLinks across the province. When we use the Innovative Practices Evaluation Framework to identify emerging and promising practices. After endorsement from the Provincial Clinical Reference Panel, this is a table of clinical experts, academics, and researchers, we will publish the guidelines in support of large-scale spread of the innovations and best practices that contribute to successful coordinated care planning. The first meeting of the Clinical Reference Panel is scheduled for Thursday, November 12th, and we hope to be able to make announcements shortly thereafter. Jennifer will introduce you to the key practices, processes, and learnings before we turn our attention to our guest panelists to hear more about the specific practices and processes that they have tested. Jennifer, you're on.
Thank you very much, Sandy. So to review, this image represents the high-level steps in the care coordination process that organically grew out of the work of the early adopter HealthLinks. Most HealthLinks seem to have adopted or adapted some or all of these steps in their processes and practices. And again, while some of the elements of the care conference are shared across many of the HealthLinks, there is variation in how this is done in each link. Typically, this step in the coordinated care planning process involves some or all of the following sub-steps. First, details around the care conference are finalized as needed. Then the team meets, and this is really the meat and potatoes of the process step. During the care conference, many HealthLinks review and confirm the vision, goals, and strengths with the patient and care team, and to ensure that the appropriate resources and supports have all been engaged. This step typically also is when the actual coordinated care plan is developed, and sometimes this is also when it's documented into the coordinated care planning template, as well as having the next steps determined. Next slide, please. Additional considerations that have emerged from the lessons learned collected so far from around the province include the following. The first consideration is about ensuring that the patient wishes are elicited and accommodated. Some patients are quite comfortable being in a room with their care team and actively participating in the care conference. Others may find this overwhelming or stressful. So you may wish to attempt to support your patient by suggesting alternative media, such as participating by teleconference, or bringing along a support person, or supporting them to develop some ground rules that are used during the care conference. And again, this is consistent with the overall emphasis on patient engagement and truly patient-centered care that we see with HealthLinks. The second set of considerations is around the logistics of the care conference. Who comes? How is this done? Some HealthLinks aim to have the full care team meet. Others pull together key members of the care team, and others have a mini conference with select members of the care team as the initial care conference and determine next steps from there. Some HealthLinks aim to bring the care team together face-to-face either by coordinating a date or utilizing more of a round/standing meeting approach. And others utilize technology, such as telephone or video conferencing, for full team participation. The third consideration is around the timing of the CARE conference. We are going to hear more from the East Mississauga HealthLink soon about the work they have done that really supports early case conferencing. The fourth and fifth considerations are about how to optimize the CARE conference and manage the interdisciplinary team during and after the CARE conference. So you may wish to ensure that you leverage this wonderful opportunity for communication that comes by having the full team together, by fleshing out as many details as you can, such as clarifying roles and accountabilities, defining what members of the team will take on which elements of the plan, and by summarizing the messages to ensure that communication is clear across the team. It may also be efficient to use this time to establish the next steps, such as how will the care plan be updated and how will that be triggered, and when you will come together as a team again if this isn't already built into your regional processes. So with these themes in mind, we're now going to turn our attention to our guest panelists to hear more about the specific practices they've been exploring and trialing. I did want to be very clear that before we go into learning more about the case conferencing practices, we're going to step back and look at what we were speaking of at our last session, the patient interview. We're going to begin with Chris Archer and Tracy Koval, who will be speaking to you about the patient interview. We were unable to hear Chris and Tracy during our last webinar due to some technical difficulties and have invited them back to speak with us today, as we know that there's been a lot of interest in the wonderful work they've been doing in the North Simcoe Community Health Link. Following Chris and Tracy, we'll return our focus back to the care conferencing practices. So first, I'd like to reintroduce Chris Archer and Tracy Koval. Welcome.
Thank you. Can you hear me?
Yes, we can. Thank you.
Perfect. Amazing. Okay, so Chris is here, but I, Tracy, will be doing most of the talking. So like you said, we are going to go back to the intake process and describe a little bit what we do at the North Simcoe Community Health Link. So the very first thing I want to mention is one approach that we've taken here at this Health Link is to really do a primary care provider approach. Where they're really at the forefront of the services that we provide. So we really try to get them to agree to participate in the Health Link prior to going forward. So as opposed to going forward with all the data from the hospital, we've actually approached physicians in the community who believe in the process and the work that a Health Link could do with their clients. And then we have received their referrals from the clients that they believe would benefit from the Health Link. So that's really important in going forward with the initial intake and also the case conference to ensure that we do have the collaboration. So next slide, please. So the one thing that we're going to talk about today is the interactive web-based map that we created here at our Health Link, and that can be found on our website, which will be displayed later, but for the sake of just identifying it now, I will let you know it's NSCH L.ca, so North Simcoe Community Health Link.ca, just the initial letters of each one. So next slide, please. So when we meet with the client in that first meeting, it's about a 2-hour process. Sometimes it's actually expanded to be more like 3 hours. But we really take the time to explain in detail what the Health Link can do for the client and what our role is. One thing that we emphasize in that initial meeting is how we believe that health is not just the absence of disease and not simply related in terms of physical health concerns and mental health concerns, but we actually take a totally different approach to understanding one's health, and we focus a lot on the social determinants of health. So we try to explain to our clients, without transportation, you cannot attend appointments or even get to the grocery store to get food to survive. Without food, you may not have proper nutrition to have the nutrients vital to good health. And without education and literacy, it can be difficult for someone to read a food label or understand the impact of the food choices. So we really place an emphasis on the social determinants of health, and we use our map that we've created. Online is interactive, and I will show a diagram of that in a little while, but we really print out an image of it to identify all the different determinants of health to our client. Next slide, please. And then when we actually put the map in front of the client, the one thing that I really focus on explaining to the client is, if you could sit here for a few minutes and just take a peek at this, obviously there's probably areas that you can identify as a problem for you that limit you to accessing the things that you need, and that we could potentially help you work on. And so once the clients do that, I give them a few minutes, we then will sit and say, what was one area that you identified that we could help assist you with that would make you feel better overall or make life a little bit easier for you? And so often they can identify one. Now we ask the client to take that map with them after our initial appointment to see if they can identify other areas that maybe they have not thought about. The other thing that we do at this HealthLink is we use the Be Well survey to help engage the client and really understand where they're coming from to create the goals. So along with using the interactive map and asking the client what they identify as kind of challenges or barriers, we create the goals around those afterwards. But we also use the Be Well survey because it will help identify different areas. And we've recently added transportation questions to help us because in our HealthLink we actually recognize that transportation is a huge barrier for our clients. But it will help us identify, if there's anything else going on that maybe the client hasn't necessarily identified themselves. And then with both of those, we actually create goals with the client. So the client usually creates, 2, maybe 3 goals that we bring forward to the case conference with all the service providers to help work on for that client. So it's a very client-centered approach. So if you want to go to the next slide. So this is actually what the interactive map looks like. So again, on our website, nschl.ca, you can find this under the client tab. And what happens is if you look here, so at the left-hand side, you'll see transportation is highlighted in red. And actually, every single one of these can be selected and highlighted. And you highlight it by simply clicking on it with your mouse. And then when you have your mouse kind of over the icon and you push a key on your keyboard, it will take you to the next page. So next slide, please. So what it will do, it will provide you all the services related to that social determinant of health in our community that can assist them. So for example, transportation, these are the different services in the Midland and surrounding area that provide transportation to clients in different needs. And all of these, if you clicked on Canadian Cancer Society or Town of Midland, it actually takes you to 211. So we use that resource as a way to connect clients so that they actually understand there's other, they could call themselves or ask for assistance through 211 also. So next slide, please. This is just an example of the Be Well survey. It takes about 20 minutes for clients to complete. It is quite long, but it asks some really good questions, whether it's about social networks. And we were really trying to take a focus on the sense of belonging in our HealthLink initially, and really trying to see if we can get people connected with a social group where they'd feel like they belong to their community. And we realized that transportation, being that they don't have transportation, they can't get to any social groups. We really decided to take a focus on transportation and created some extra questions for the Be Well survey. So again, like I said, we use both of these tools to really help us develop the goals for the client with the client present that we bring forward then to the case conference. And we base the case conference on the client goals. So next slide, please. So there's our contact information. So the website is supposed to be nschl.ca, not HSCH, so North Simcoe Community Health Link. But yeah, so you'll find that online. If you have any questions, feel free to ask or contact me anytime.
That's wonderful. Thank you very much, Tracy, for agreeing to join us again and share this wealth of information. There is one question. I'm wondering if the Be Well survey is available on the website as well, or is that something you hold in your clinic?
So I actually contacted the AOHC for the Be Well survey. Now I have a copy of the one that we've created, including the transportation questions, and I have the copy of the extended version that I'd be happy to share. It is a useful tool, but I ultimately got it from the AOHC.
That's wonderful. Thank you. Tracy, if you are interested in sharing that with us, we're happy to manage that centrally here. So if any of the audience and attendees would like a copy of that, they can reach out to us. And when we post the webinar, I'll make sure that the website is correct. Thank you very much. Okay. Thanks. So we're now going to switch our attention back to the care conferencing practices. And I'm going to introduce you to Queen Young Wafor, who's care coordinator with Mississauga Halton CCAC, and Anne Mackay, who's the project manager at East Mississauga Health Link. Welcome.
Thank you. Can everyone hear me?
We can. Thank you.
This is Queen speaking initially, and then Anne Mackay will take to the end of the presentation. So in the East, next slide, please. Thank you. In the East Mississauga Health Link, our model of care emphasizes intensive care coordination with a focus on patients' self-identified goals and care conferences with primary care to address the complex needs of our patients. Here, care coordination is provided by care coordinators from the Mississauga Halton CCAC, and our goal is to complete the initial care coordinator visit with the patient within 3 days of referral, either in the patient's home or their preferred location. We receive referrals from pretty much anywhere: hospitals, primary care, our CCAC, other CCACs, and other community service providers. Next slide, please. A care conference means different things to different health links, but in the East Mississauga Health Link, we prioritize care conferencing with the primary care provider. A care conference having simultaneous conversations with the patient and family if possible, the primary care provider, and the health link care coordinator at a minimum. Sometimes other community providers are present at the care conference, but we don't hold up a care conference in order to wait for the other members of the circle of care to be present. Our goal is for patients to have a primary care conference within 7 days for hospital referrals and 14 days for community referrals. There's the shortest time frame for hospital patients, as we consider them to be, in inverted commas, open and closed, like less stable of the two groups of patients. So we aim at getting them conference as soon as is possible. Next slide, please. Just to elaborate a little bit on what happens during a care conference, the patient's concerns and goals as expressed or presented on the care coordinated plan are reviewed. Now, even though the CCP is initiated at the home visit and sent to the primary care provider before the care conference, it mostly serves as a preliminary reference point from which discussions around patient's goals are started. The patient's eventual care plan is, however, set collectively by the primary care provider, the patient, and other parties present at the care conference, as the case may be. Now, care conferences generally take up different formats. They could be led by the primary care provider, and this usually happens when the primary care provider is the referral source for this patient, so they're abreast of the situations that the patient is currently facing. Most often, though, it's led by the health link care coordinator that serves as the facilitator, especially when the patient is referred from hospital or community, and the primary care provider is maybe not so aware of the current patient's current state and or the care conference process. Sometimes we have it, and this is rare, but we have had it led by the patient when they're quite eager to drive their own health care. At the care conference, the health link care coordinator attempts to familiarize the primary care provider with the health link process as a whole, like tell them what reports would be expected at 30, 60, or 90 days, as the case may be. We also review the CCP with the patient and those present at the care conference, including medications, goals, circle of care involved, and follow-up appointments coming up, just to empower the patient to actively participate in their healthcare goals. And the care conference generally usually holds in the primary care provider's office, but it could also hold in the patient's home, either with the PCP there present or through video or teleconference. Sometimes we get the primary care provider to come to see the patient in their home for elderly patients or mobile patients, for example. Next slide, please. We've often heard reports from our patients about the benefits of the care conference. We've heard that it makes them feel empowered, gives them a voice, and enhances their relationship with the primary care provider. And as a result, it breaks down barriers between them and their primary care providers. We have also often heard that it increases their face-to-face time and attention with the primary care provider during subsequent visits. And this is for patients who have had the same primary care provider for as little as 2 years, and those up to even those who have had it for up to 30 years. They tell us after the care conference, they actually feel like there's more face-to-face time with their primary care provider. And also they have told us that after a care conference is done, they actually feel like things are moving and changes happen. From the primary care providers, we've heard that they feel more informed of their patients' issues and services that are available, as well as the services that their patients may already be receiving. They feel assisted while addressing their patients' complex issues, and they have a responsive point of contact, which will be the health and care coordinator in the community, with whom they can easily communicate. On our end as health and care coordinators, we find that we're building more positive relationships with the primary care providers, which in turn enables easier access to their services, thereby kickstarting care more efficiently and effectively. Now I'll hand over to Anne Mackay.
Okay, thank you, Queen. So since it's been a priority of the East Mississauga HealthLink to have care conferences with all our patients, we thought it was also therefore important to track some of our process indicators as well as outcome measures, so that we would be able to comment on whether or not this had been a valuable part of our model of care. Our first observation is that only 55% of patients enrolled in our HealthLink have achieved a care, and additionally only 39% of those that have the care conference have it within the targeted time frame. So you can see that even when it's a priority for us, it is still challenging to get a care conference, and getting a timely care conference is even more difficult. We have taken a fairly deep dive into understanding why care conferences don't occur or why they are delayed in occurring, and we most frequently see that this is related to patient choice. However, there is definitely an element of availability or access to primary care, as well as scheduling for the care coordinators, and of course location and technology. All of these factors do play into things in time. So when we look at outcomes, then we have measured, we have tabulated the number of visits that our patients have had to the emergency department in the 6 months post their HealthLink enrollment, and compared that with the 6 months prior to enrollment. And so overall, we see that there is a decline in the number of visits that our patients make to the emergency department, but there is a greater decline, a 39% reduction in in emerge visits for those that have the care conference compared to the actual numbers here translate to about a 20% differential between the two groups, those with and without care conference. And when we stratify findings by the timeliness of the care conference, we see that those with the care conference actually have a 56% reduction in their emerge visits when that care conference occurs within the targeted number of days of either 7 or 14 based on their referral source, compared to 23% for those with a care conference that was more delayed. Next slide, please. So we want to finish our presentation with you by summarizing a few of the lessons that we've learned. Certainly, I think you would all agree that personalization of care does have a great impact on patients and their outcomes. And we've really seen this with respect to the care conference, where when we take the time to explain in a group setting the extent of patients' goals and challenges and the issues that are limiting them at home as a result of what's often been a home visit for that first initial assessment, patients are expressing that their relationship with physicians and primary care has improved, and next time they will go visit their primary care provider or even call a care coordinator as opposed to going to the emergency department to deal with what might have been felt as an urgent issue that they needed to go to the emerge for. Additionally, the HealthLink care coordinators have worked hard and recognized that taking an initial no to having a care conference is not in anyone's best interest, so they now work really hard at building rapport with receptionists and ask them to engage the physician rather than answering on their behalf. And the same with patients, asking patients to go back to their doctor and ask them, what about having this care conference? So a lot of work has been done there, and that's been quite helpful in advancing our ability to have a care conference. Finally, physicians do communicate to us that they want greater clarification on their remuneration options for care conferencing, as it is an expectation of greater time spent on their part. So overall, we would say that primary care conferencing has definitely been effective in reducing emergency visits and helping our patients to meet their self-identified goals. However, this is difficult to achieve for all complex patients. And we've also noticed that our greatest impact has occurred when that care conference occurs early. So we have our contact information on the last slide. So after this presentation, you're more than welcome to contact us if you want more information. Thank you.
Thank you very much, Queen and Anne. We do have a couple of questions that have been chatted in, so I'm going to ask Stacey if she could relay those along.
Sure, absolutely. Okay, the first question is, out of 10 patients, how many case conferences would you have with more than 3 members of the circle of care that are not the patient?
Not a high percentage, maybe 25%. We do have care conferences, subsequent care conferences sometimes that have more members present as a result of having had our initial care conference with primary care.
Okay, great. And then the next questions are if you could elaborate on how the CCP is shared with the circle of care, as well as what the billing code is for MDs that you use for the care conference.
The CCP is sent from our office mostly by fax to the circle of care members, first of all, the primary care provider, as well as any other service provider that is actively involved in the patient's care. And we also we initially started by sending the CCP automatically to the patient, but some patients prefer us to handwrite a little note for them during the visit, and so we do that as a little note. But they do have in their records, the permanent electronic records here at the CCAC. The CCP is there for reference for future use.
Regarding billing codes, I can't give you exact billing codes that are used, but I mean, physicians are able to bill for, counseling. They're able to bill for interacting with the CCAC, and having conferences. I think one of our limitations is that our care conference does sometimes have only 3 or 4 people present, and some of the billing codes require a greater number of healthcare professionals to be present for the conference in order to, use some of the other billing codes. So, yeah, this is not something that we have worked out thoroughly, but I will tell you that it's not the most common reason why we don't achieve a care conference. So we generally have found physicians have benefited so much from the dialogue that has resulted from the conference that they have actually contacted our coordinators subsequent and said, can we have another conference, because this really helped in the patient's care.
That's great, thank you. So we've had some wonderful questions being chatted in. Please continue to chat your questions in. And if we're not able to answer them while on the line today, we'll make sure we get back to you via email. Thanks again, Queen and Anne. We are now going to invite Robin Griller, who's the director of the Mideast Toronto Health Link, to share some of their practices. Welcome, Robin.
Thank you. You can hear me?
Yes, we can.
Excellent. Okay, if I could get the next slide, please. So the Mideast link just is a second wave link. So we launched our care coordination pilots in January, February of this year. And our focus, while we're working with all clients with complexity, is on those living with mental health and addiction challenges. And we're using what I would guess I could describe as a dispersed model. And by that, I mean that clients are being identified and engaged in care coordination in a broad range of settings. So we don't have a particular setting that is doing the identification. We don't have, you don't have to refer into a central team. Each individual or health service provider providing organization can identify clients and engage them in the care coordination process. And the reason we've gone this route is that with the limited resources available to Health Links, our goal was to build capacity for care coordination in multiple organizations. We have over 50 health service providing organizations in our Health Link. And so we needed those individual organizations to have the capacity to work with clients wherever they're identified. So they might be identified at the hospital, they might be identified in the organization. We wanted to make sure that there was capacity and skill in each of those organizations. Next slide, please. So initially we started with 6 programs, and then we added another 10 settings that joined the pilot phases in the second quarter of piloting, and other organizations are joining as they're ready to go. So far we've got community mental health programs and organizations, community support services or seniors programs, primary care settings, and hospital actively involved. And when I say mental health, I just want to clarify that's a broad range of mental health settings, including intensive case management, supportive housing, programs that are providing supports in community housing buildings and so on, a lot of different settings. And a number of the care plans have included the hospital, and formal identification and engagement of clients at the hospital is now underway. Next slide, please. So the case conference, you can go right to the next slide. So just as a background, one of the challenges in the HealthLink implementation is the limited resources available. And when you add in a dispersed model, it means we don't have a formally standardized practice that we can say is being implemented exactly the same way in many different settings. We just don't have the resources available to be able to support that kind of standardized implementation. But I think there are some key elements to efficient and productive care planning meetings. And this is especially when working with people with mental health and addictions challenges. And I would focus on 3 areas. So the first is that the focus really does have to be on the client's goals and choices. And that's got 2 components. In working with people with mental health and addiction, if you want to work with the client on issues that the health service providers might think are important, you really have to start first with the issues that the client thinks are important. If you don't do those first, you will not build the trust and you will not build the relationship that's necessary to get people to work on other things. Now, I think back to when I was working at a family health team, and we started a diabetes program working with homeless men, and a guy with fairly serious illness told the nurse, I don't care if this diabetes kills me. I'm not changing how I eat. I'm not changing how I don't exercise. I'm not changing anything. And the nurse came to me and said, what am I going to do? And I said, well, is there anything that he does want to do? And she said, oh yeah. And I said, well, do that. And she did that. And a few months later, the same person came up to me and said, you know what, I just do whatever she tells me. If she tells me I can't eat X, I don't eat it. And it's about building that relationship and that trust that allows you to get the client to engage with you on the things that you think matter from a health perspective, because you've worked on the things that they felt matter and demonstrated your commitment to their well-being. And the second piece of this is focusing on who does the client want in the room. Our goal is to have the entire circle of care, if possible, involved in the care planning process. And so we start off with a conversation about who are the people who help you out. And we do this broadly. So that means health service providers. It means social service providers or providers that the client may not think of as a health provider. And it includes informal support. So, when some of our clients may have the PGT involved, they may have someone from their faith community involved, they could have all kinds of people. And if those are the people that they want participating in their care team and the people who really help them out day to day, then they need to be there. Second piece is around flexibility in the case conference, and this is where we're getting really to the crux of the case conference. Clients with mental health and addictions will want to participate in different ways, and from we have had individuals who've wanted to go through each item of action identified and who's doing it, and make choices about who's doing which pieces and what they look like and how they get done. To we have other people who say, you know what, go ahead and have a care planning meeting, but don't expect me to be there. And that's fine. And the clients need to be able to participate in the manner they choose, not in the manner we choose. And the final piece I would say is waiting for perfection will be a long, long wait. As I said, our goal is to have the whole care team in the room, but if the client says they don't want parts of the care team in the room, parts of some of the people who provide care to them there, then we go with that. Our take is if the client is willing to have a care plan that involves 3 of their 6 providers or 5 of their 10 providers today, they may choose later to have all 10 in the room if we demonstrate that the care planning process benefits them, is safe, and that they get to make choices and they don't lose control entirely of their lives in the process. And so we would rather have a care plan with part of the circle of care, or work on some of the goals, not all of the goals that we might have, but the goals that the client has, in order to get from the imperfect current care plan that's as good as it can be in the context to the care plan that we'd like to have in the long run. So next slide, please. So one of the things that we've done is we've tried to have the case conference as much as possible just focus on 2 areas. We don't, while we're using the ministry care planning tool, we don't think it's beneficial to go through the entire care planning tool in the case conference. There are really 2 areas we feel need to be focused on. The first is we focus on goals and actions, and we start with the client's goals, and really focused on the client's goals. If there are things that the health practitioners would like to have in the plan that the client isn't so keen on, there can be a negotiation around that, and hopefully you can get it included. But at the very least, you need to deal with the client's goals. And we focus on the goals, the activities that are related to those things that need to be accomplished, and who's taking responsibility. And so the second piece, and really if it's not client-driven, it's not going to be effective with a mental health and addiction population in our experience. Finally, second, in terms of the roles and responsibilities, we do 2 pieces, agreeing who will be the care coordinator. And in our case, the care coordinator could be in all kinds of places. It could be a case manager in a mental health program. It could be a nurse in a primary care team. It could be a seniors case manager in a seniors program. It could be a housing support worker in a housing team. And so really it needs to be the person who has the capacity to be organizing the team and following up with people, and can be the go-to person for the client on a day-to-day basis, and who the client feels comfortable and safe with organizing their team. And then the other team members, are committing publicly to a set of actions, and this has been really beneficial. We've had a number of care plans where clients have been in danger of losing housing, or in really difficult situations where everybody's willing publicly commit to carrying out certain actions to support the client to resolve the issues that are resulting in housing insecurity, help the housing provider to feel much safer and much more supported in successfully doing so. And it's also helped the primary care practitioner to engage effectively with the other service providers without having to seek things out in a time-consuming manner. And everybody in the process commits to keeping the care coordinator up to date and remaining engaged in the client's care. We've had a number of situations where practitioners or organizations have been worried that they would be left holding the bag with the client, and other people publicly committing to say they will not disappear without the prior agreement of the care coordinator has been a really effective way to resolve some of those concerns. Next slide, please. So the lessons learned, I would say, is that, identifying and engaging with the client where they feel safe and valued and respected is really important for this population. Structuring the case conference to be responsive to the individual client's preferences about how they participate is really fundamental as well. Clients will say they're going to come to the case conference and not show up, but they fully expect you to continue and do the job and follow up with them about the care plan afterwards, and that's fine. Or if they want to be more actively involved, that's great. We're finding that if we complete as much of the care planning template outside of the case conference, so that we can really just focus on the plan in the meeting, that's really effective. And we have a really broad definition, like some of the other links, on what is a health-related goal. Our clients, we've had care plans that have focused on things like people with long-term mental illness who want to return to employment, and put a lot of effort into developing a plan around first steps on those roads and things like this. So really being broad, if we respond to the issues that the clients are really concerned about and really want to focus on, we might be able to get them to work with us on those other things. And I think that comes down to the next step point, which is that it's not focusing on client goals is fundamentally different from focusing on practitioner goals, and often will require flexibility and negotiation on the part of healthcare providers. And I think there's a really big culture change happening here around negotiating to work with the client on the things that matter to them in order to be able to then build those relationships that help you get to the things that you care about. We've had a number of clients who in the process have said that, coming out of the care planning meeting has changed how they feel about their healthcare providers, that they now believe that their healthcare providers actually care about what happens to them because they're willing to respond to the things that they think that they value, and not insist that they only focus on things that the client may not value as much at this point. And the last thing I would say, which is a real challenge given the limited resources in HealthLinks, is that different organizations and teams in a dispersed model will experience extremely different challenges in care coordination, require a lot of different supports to have success, and that it's with one staff person, it's sometimes a challenge to provide those supports, but we're doing the best we can. And that's the end. Next slide. And that's my contact information. Feel free to contact me if you have any thoughts or questions on the subject.
Thank you very much, Robin. We have had a question come in on the line, so I'll pass you to Stacey.
Hi there. The question is, when do you decide who will be the care coordinator? Is it during the care conference or earlier?
It's kind of a combination of both. I mean, we start out with someone is identified, when a client is identified in the service providing organization, they will often have someone who is willing to take on the care coordination role, and that person will meet with the client, have engaged them in the process. It's usually someone who has a good relationship and can start the process off. In the course of the case conference, there's actually a discussion of who's going to play the care coordination role, and so that if the client has someone else in their circle of care who's better placed to do it, or where that the client feels more comfortable with, that conversation can happen and a different person take on that role. It doesn't happen very often that it turns out to be someone else, but it has happened. We've had cases, for example, you know, in working with some of our community mental health and CCAC partners, where we've had a person identified in a setting that may not have care coordination, as say a hospital or something like that, and then we get the CCAC or someone else to come in. They'll do the care coordination up to the care planning meeting, and if it turns out there's someone else in the circle of care who can take on that role, they'll pass it off. Or similarly, if it may be the CCAC person may have another CCAC care coordinator who has an existing relationship, and they'll pass it off to that person. So it starts with one person, but then at the case conference, it's normally agreed during the case conference as to who's going to be the care coordinator.
Great. And how do you keep the circle of care up to date with any care plan changes?
Well, that's a major challenge, and I'd have to get some of our partners on the line to answer that question properly. I mean, currently what we're doing is we're sharing the tool. It's being shared on a paper basis, right? Because we don't have an electronic system in place to share the care plan, which makes updates really challenging. I think, you know, that is a question. As again, I'd have to go back to our partners to say, how effectively are you able to do that? Because it's a challenge, right? When it gets changed, then updating and then share out paper is not a really effective and efficient way to do it. So we're really looking forward to the implementation of an electronic sharing system to allow those changes to happen more efficiently.
Wonderful. Thank you very much, Robin. If we have any further questions, we'll be sure to send them to you via email. Thank you. We're now going to introduce Mary Wheelwright, and she is the Director of the Health System Integration at Headwaters Healthcare Center. Welcome, Mary.
Thank you. Thank you for inviting me to speak here. I found this really interesting, hearing the other challenges that some of the other groups have had, and a lot of them are very similar, and so I'm really valuing this. I guess you could move to my first slide. So what we've done at the Dufferin Health Link, we've been very fortunate because we really, the two leads of the Health Link are the hospital and one family health team that essentially covers most of the physicians. I think all but about 2 in our entire region are part of this family health team. So when we decided we needed to do we knew we needed to do some community, our rounds to try and do our care planning with these patients, we'd already had quite a broad range of community partners that were part of our steering committee to get going with the Health Link. So what we said to them was, okay, if we can set aside some time each week, will you people commit? And it was a little difficult at first because people were sort of thinking, oh, I can't, promise an hour and a half every week. What they found was it was well worth their while. But so what we've done is that we have people from the family health team, so some of the nurse practitioners, sometimes they're mental health workers, community mental health workers, people from Alzheimer's Society, the CCAC case coordinators, housing, people from housing. If a patient is we're having issues with where they're living, those folks will come as well. And we set aside a regular once-a-week time that rotates through the various sites of this family health team so that we cover off all of the physicians. So each physician has an identified CCAC care coordinator as well. So that's something that our CCAC has done. So we know, if you know who the physician is, you know who the care coordinator is. So in an effort to not be making care coordinators have to come to all of them, we say, okay, this first week we're going to do these 4 docs, which are these 2 care coordinators, and the rest of the team agrees to come. So we have those meetings set up regularly. We realized as well, if we wanted the physicians to participate, because that's always a challenge, you need to make it easy for the physician. So we needed to do it in their family health team locations, and that way the physicians can come and join the discussion for those patients. The third thing that we sort of made ourselves commit to, and this is similar to the others, is that this is about the patient and their goals and the primary care physician. Those two pieces, the patient and their goals and the primary care physician, need to be working together, because they're really the people who are driving this, the patient and the primary care physician. So they need to be at the center of the circle of care. So the way we've set it up, maybe you can go to the next slide. I'm sort of just talking through this. So next slide. So yeah, the Central West CCAC have aligned their care coordinators with the primary care physicians, so that already has made things easier in terms of organizing these. And we were having care planning in the community, but it didn't include everybody, and it certainly rarely included the primary care physician. So when we got everybody around the table, we said, look, we're already doing this. Why don't we do it a little bit better? Let's figure out what are those barriers for the primary care participation. And so we combined the rounds and we hosted them at the various locations. And everyone knows that's in your schedule. That's when you come each week. So it's a little bit different than some of the others in that we've got the group there, and the way it works is that each week, if there's somebody in the community that you're concerned about, so it may be the physician, it may be a community paramedic, it may be somebody from Alzheimer's, it may be the CCAC care coordinator, it may be our gem nurse at the hospital says, we need to talk about this patient. When's the week that physician, we're talking with that physician. So the names are put forward. The expectation is if you're going to put that patient's name forward, that you've spoken to that patient. So these rounds are almost more kind of problem-solving rounds of figuring out what can we offer the patient. There are times when we say, no, we really need to have the patient there or the patient wants to come. In those situations, we usually schedule those at the beginning or the end because they don't want that huge group of people. It can be really quite overwhelming. The other thing is not everybody around that table is necessarily involved in that particular patient, but they're all very knowledgeable people. So when we speak to the patients about it, we can say, listen, I'm meeting once a week with a number of people. Some of them are already involved in your care. Others are really just really smart people who may have some good things to suggest. Are you okay if we do some problem solving around some of the issues that we're working with today? And invariably the patients are like, yeah, that's fine. So we have our rounds, we know who we're being identified, the names are sent out ahead of time to the team with the information. The person who's recommending that patient be discussed, their obligation is they need to make sure that the patient knows that they're being discussed and what are their goals. What are the most important things that the patient wants to have so that we can do some problem solving around those issues. And then same kind of thing as with the last speaker, we may figure out who is going to be the care coordinator, and then that person then will go back with the patient, connect with the patient and the primary care provider and some of those other providers and get the care going. But this is kind of our problem-solving round. As I said, some of the community partners weren't sure that they could commit to this time. What they found was they said, gee, you know what, I used to meet with the patients and then I had 45 minutes of phone calls to make afterwards. Now I don't have to do that because everybody's around the table. And what we found is that now you've got these partnerships built up. Now you've got these relationships. So an awful lot more care planning is going on. We have a much better idea of who has what resources, who's available, who could do something. And so it's really, we're doing more than we expected. We also always make sure we have frontline staff, but we also have an agreement that somebody from a sort of a more management level from either the CCAC, the family health team, or the hospital needs to be there because we're pushing the envelope a lot. And it's not fair to expect a frontline person to say, well, I know I'm not allowed to put in this service, but I think I'm going to. So it's important for us to be able to identify those gaps, to see where some of those barriers are, that we do have somebody who then kind of brings things back to the the management team to say, okay, this is a problem. You know, there's a restriction here, there's a barrier here, it's limiting our ability to meet these patients' needs. What can we do to resolve it? Next slide, please. So our lessons learned, as I said, there are sometimes concerns about patient privacy. Not everybody around that table is necessarily a regulated health professional, so it's important that the patient understands what's going to be discussed, and if the patient says, no, I want to be there, as I said, we'll bring them in and have a smaller group. What we've done is we met with the privacy folks from a couple of organizations. We put together kind of a privacy statement, and everyone signs off on it at each round. So that way we have a record of exactly who was there at each round as well. As some of the other speakers have identified, sharing care plans can be really difficult. A lot of them, some of them were built on the primary care EMR, but then not everybody has access to that EMR. A lot of the times the CCAC care coordinators are doing them. Again, who's got access in terms of updating them? If the CMHA care providers are doing them, that's a different database. So we were doing a lot of faxing back and forth, and we're still doing that. The expectation was at the end of the care round, someone would be meeting with the patient. That care plan would be in place within the next 5 days and would be sent out, faxed out to all of the care providers. Still not a great system, a lot of paper heavy in the updates, because these things are really living things. They're changing often weekly. We've been piloting the web-based ministry tool, and that is going to help things. We're still working out some of the kinks of the pilot project, but that's a much easier way because we've given access to anyone who is part of that care plan, then would have access, so they could go in and update that care plan. Because that was a big problem, was updating them, and also often care providers weren't necessarily even aware of who else was involved in the care of that patient. The other thing that we've learned, as I said, was that all of our community partners and our primary care physicians are becoming much more familiar with supports and services. When we first started this process, we had physicians who'd been practicing in this community for 25 years. And we got everybody around the table, and there were people there they had no idea existed. They also had no idea that these people were involved in their patients' care. So we're realizing we didn't necessarily have to bring in new services, we just had to make sure that we talk to each other a lot better. And about the only new service that we've really brought in is our community paramedicine program. But the rest of it is people who were already there, we're just talking better. I think that's about it. Next slide. I think that's my contact information. I've had my timer here on the desk so I don't speak over. So that's about all I've got to say. I'm sure there are questions, and I'm more than happy to answer them.
Thank you very much, Mary. We do have a question that has come in on our chat line.
The question is there any safety net for the care coordinator when he/she visits a complex and possibly agitated or angry patient in the home?
Well, there's always 911. But one of the things we have, again, that comes out often during our care plans are who's got a good relationship with that patient. So often it's someone else. It might be the community paramedic. It may be a community mental health worker who's worked with that patient for quite a long time. So where the CCAC case coordinator, for example, might not know that patient, but we really do want to put in a CCAC service, they'll arrange to attend with the CMHA worker, for example. So those are some of the things that we're always there, but they seem to be a lot more easily organized because people know each other better, and we've got everybody around the table. Does that answer the question?
Thank you very much.
What role does your community paramedic play in the care plan?
They're amazing. The community paramedics are sort of one more piece of the puzzle in terms of services that we've got. So the community paramedics can often do wellness checks. They'll do simple lab work. They can do sort of visits with patients. So one of the things that we find they're really good at is getting in the door. So a lot of the times these patients are quite resistant to having help. The paramedics are often the ones who are the first ones that can get in the door and can say, no, you know what, they're okay with this, this, and this, but they really need some help with that. So in a lot of situations, there are eyes and ears in the home that they've been able to get there even if, if the patient isn't eligible for CCAC or hasn't got a CCAC service in place yet. The community paramedics are often, they can get in there. So they're part of the team. They don't usually create a care plan, but they will often, the web-based care tool that the ministry is piloting, you have authors and viewers, and we've arranged for a number of authors, so there'll be people that will be maybe responsible for the majority of it, but all of these other care providers can then update. So the community paramedics will also be able to update that care plan to say, I was in, they've agreed, they're willing to have an addictions worker come in. And that way that information is there for the whole team to see. So there are eyes and ears, and they're also part of the creating and maintaining of the care plan.
The next question is, do you have case conferences for all your clients? Out of 10 patient referrals, how many would have a conference?
Not in this format. Now, the other thing that we do have is, in terms of my proportion, that's a tough one. I'm not really sure whether I could answer that question. Maybe, I'm guessing at 25%. But the other thing that we do have is with the CCAC model with the primary care physician. The primary care physician has their CCAC case coordinator, and part of that arrangement is that every 6 weeks or so they meet directly with that care coordinator. So that's another opportunity for them to have some care conferencing where they maybe don't need everybody around the table. We also have our family health team has identified that they've identified someone who helps, her role within the primary care team, the family health team, is to help those physicians identify some of these patients who are at risk for readmission and to get that kind of planning going with that physician. So there'll be different levels of care conferencing for those patients. It may just be the care coordinator and the physician, or the primary care nurse and the physician to say, okay, this patient, she's been in emerge for the last, once a week for the last 3 weeks. We need to talk about her. So there are different levels of care conferencing happening with this particular format. I would say it's less than 25%, but these are the really, really complex patients. Our goal is to get up to sort of, 8 to 10 patients a week that we would be discussing. We're not quite there yet, so that would increase that number.
Great. Wonderful. There was one follow-up question, just clarifying if you said that the community paramedics do blood draws in the home.
Yes. They do. They can do some simple lab work. Now, we have to be really careful that we don't use them as opposed to, there is a traveling lab that will come and do lab work. That isn't their role, but what they've done, for example, is they can do some simple blood work. They can do simple urinalysis. So, and they also have access to our primary care team. Our family health team has one EMR system, so they'll actually be able to connect directly with the physician. An example of how they've been used, we've got a patient who's on the telehome care program. The telehome care nurse called the family doctor to say something's not right with this patient today. She was able to call a community paramedic who was able to get out there, do some blood work, recognize that the patient had a pneumonia, got a prescription written right away, so the patient was able to be seen, treated, and didn't have to come into emerge.
That's wonderful. Thank you very much, Mary. That's great information. I'm now going to invite Sharon Howlett to speak to us. She's the Provincial Lead for Health Links and Telemedicine Nursing with the Ontario Telemedicine Network. Welcome, Sharon.
Thanks, Jennifer, and hello, everyone. You can go to the next slide, please. So as you work towards implementing best practices in your health link, OTN would like to encourage you to leverage e-visits as a best practice when conducting a care conference. So what exactly am I referring to when I say e-visits? Well, e-visits is OTN's new branding for video conferencing, which can be done in a number of ways. I'm hoping that you're familiar with room-based video conferencing or traditional video conferencing, where an OTN system is located in a specific room at a healthcare organization. Healthcare organizations have previously spent a lot of money on these systems because they are very, very expensive. So certainly in the HealthLinks environment, we encourage healthcare organizations and the HealthLink to leverage those systems. However, it's not always feasible to get everybody into a room at the same time, and so we want you to encourage you to use other options. The second option is OTN Connect, which is using personal video conferencing on your PC or your Apple computer with a fixed or wireless internet connection, or mobile video conferencing, which is using a tablet, a laptop, or an iOS device using a cellular internet connection. And a third option is something new to OTN called OTN Invite. This is using personal video conferencing and sending a secure link to a healthcare provider or a patient who has a computer device but does not have OTN. Now, in the HealthLink environment, we advocate using OTN Invite with a healthcare provider only who does not have OTN. It can be used with a patient, but given the complex nature of patients, generally speaking, we recommend that a healthcare provider is present with the patient and the patient is not receiving the link on his or her own. Next slide, please. So this is a visual of the care conference using e-visits. In the center, you have the patient and a healthcare provider who is located in his or her own home environment. They can connect to a number of care providers, physicians and specialists, primary care, community providers, and family members using any number of the e-visit options, room-based video or traditional video conferencing, OTN Connect, or OTN Invite. This can be done in a multi-point fashion so that each participant can remain in their own location. Next slide, please. There are a number of key benefits to using e-visits for care conferences. The number one key benefit is that the use of e-visits enables you to bring care to the patient instead of bringing the patient to care. This has the additional benefit of the patient remaining in his or her own environment, which increases their comfort level, decreases the anxiety associated with meeting with an entire care team, and decreases the burden associated with travel to care. Additionally, for all the participants in the care conference, the use of e-visits eliminates travel that is both costly and time-consuming. This, in turn, can make scheduling a care conference faster and easier, and it allows you to increase your capacity and effectiveness, which overall will empower a more efficient HealthLink. Next slide, please. So this is just a sample of some material that we've developed that I want to talk to you about. OTN has 5 HealthLinks that are currently utilizing e-visits for their care conferences, and we are working with 9 other HealthLinks that are in the implementation phase. In the Toronto Central LHIN, there are 4 HealthLinks that have been using e-visits within their telemedicine Impact Plus model of care. They use e-visits solely for care conferencing, and the results that they have demonstrated are phenomenal. Physicians and healthcare providers have indicated that the use of e-visits reduces silos and advances patient care. And the patients themselves have indicated that they feel much more comfortable meeting with their team when there is the distance or the barrier of a computer in front of them. It's a lot less anxiety-provoking to be able to meet with the team but not have them right there physically face-to-face in the same room with them. The Southwest York region conducted a remote specialist consult. So it was not a care conference, but they did it with a HealthLink, so more of a traditional OTN visit that people are familiar with. And from that, we developed a video vignette, which is an interview of the care provider. So this care provider spoke about how seamless and efficient it was for her father, who is an elderly gentleman and lives in a retirement home, to be able to meet with the specialist in the retirement home and not have to travel a total of 6 hours for a 15-minute appointment. And it would have been 6 hours when you factored in time to and from the hospital, as well as wait time at the hospital. This gentleman was able to get up in the morning and go to the dining room for breakfast. He was able to then return to his room where the care coordinator met with him and in a multi-point fashion met with the physician and the caregiver.
The caregiver was able to participate and translate for her father, and she didn't have to take off an entire day of work. She was able to attend at an OTN site that was close by for her. So the use of e-visits in care conferences certainly has its benefits, most particular to the patient and to the care team, and something that we definitely want you to consider in using. OTN provides a very high-touch approach. We include clinical process and design when working with the healthcare team. We include technology implementation and very high-touch technology training. Next slide, please. And if you are interested in having an electronic copy of that case study that comes out of the Toronto Central LHIN, or viewing the video vignette that comes out of the Southwest York region, please don't hesitate to contact me. If you'd like more information in terms of health links that are working with us to use e-visits for care conferences, please contact me as well. Thank you.
Thank you very much, Sharon. There are a few questions on the line for you.
Great. Could you let us know how many OTN sites there are in the province?
That's a good question. Over 3,000 and counting, and I say and counting because every day we're bringing on new sites, and that's actually just the physical locations. That's not counting the personal computer video conferencing locations. So if you take into consideration those, we anticipate bringing on an additional 6,000 personal computer video conferencing users this year, and we're well underway in meeting that goal. Pretty much, you can be certain that OTN is located in every single hospital in the province of Ontario, every single CCAC, every single LHIN office. Numerous family health teams and CHCs are connected to OTN. As well as a number of community providers and mental health organizations. And again, that is just in the room-based traditional video conferencing fashion across Ontario with personal video conferencing. Again, we will go over the user number of 6,000 this year.
There is a question about what enhancements will be made to improve the connectivity issues.
So certainly with personal video conferencing, when you're not using a fixed or a wireless connection, you're using a cellular connection, you are at the mercy of the cellular providers. You are at the mercy of how many people happen to be on the internet at any given time of day, and you're at the mercy of bandwidth fluctuations. There's a lot of environmental factors that come into cellular use that we don't have control of, such as concrete. You know, I think it's known that in rural areas there are sometimes less bandwidth available, but that's not just in rural areas. Sometimes you can have more bandwidth connectivity issues within a urban area where there is a lot of concrete. So given that OTN doesn't have control over the cellular technology, certainly what we are doing is developing a second pilot that will look at trialing a number of different devices and a number of different connectivity modes, so hotspots and wireless sticks. We're hoping that from this pilot we will be able to produce a gold standard in terms of the device and the connection as the cellular technology continues to improve.
The next question is there technology available for the community hospices?
Is there technology available for the
community hospices?
Absolutely. There's technology available for any healthcare organization, including hospices. What we find is that a lot of smaller organizations now are accessing the personal computer video conferencing technology because it is a lot less inexpensive than the traditional room-based video conferencing. We also find that a lot of the larger healthcare organizations, as they have to replace their OTN systems, are using the personal computer video conferencing technology. You know, there is not any, you know, large fees in terms of $20,000 for an OTN system. You're looking at the cost of the device, which you're responsible for, so a computer or a laptop or a tablet. You do have to ensure that you have business-grade internet, which you're also responsible for, and have a webcam or an integrated camera, as well as an external speaker. And those peripherals run about $100 per piece. For any Ministry of Health funded organization with base operations funded greater than 50%, there are no user fees, there are no setup fees. So it's a very, very economical way for organizations to now use OTN. And that includes hospices. We do have a number of hospices that are on our network.
Another question, what is the difference between OTN Connect and OTN Invite?
So OTN Connect is basically personal video conferencing or mobile video conferencing. OTN Invite is a secure link. So you have at one endpoint a person who has personal video conferencing or OTN Connect, and at the other endpoint you have somebody that has nothing. They're not on the OTN network at all. So in the HealthLink environment, where it would be particularly useful is with your primary care physicians who aren't on the OTN network. So we do have primary care physicians on the OTN network, and we are increasing that number every day. But certainly there is a lot of room for growth there, and that is where you could access your primary care physician without he or she having to have OTN. It is also used with the patient. So we have organizations that in the case of palliative care, the healthcare provider is providing palliative care to a patient that's located in a hospice or his or her own home environment. And that patient obviously does not have OTN. They're using that secure link. What should be called out there is that you want to make sure that your patient is appropriate. And certainly in the HealthLinks environment, what we've found is that using the OTN Invite is appropriate if you have a healthcare provider with them. Again, it's a encrypted endpoint to endpoint. So it's no different than OTN is now. It's just using a different way of connecting.
Just to follow up that question, have either OTN Connect or OTN Invite been explored in northern or remote areas? And if so, what are some of the lessons learned?
OTN Connect and OTN Invite has been used all over Ontario, including the northern areas. Some of the lessons learned, definitely, if you're looking at using OTN Connect in a mobile way, so mobile video conferencing, a lesson learned is around the bandwidth and the fact that it's very, very important that you have backup plans when you're connecting using mobile video conferencing or using a cellular connection. And this is true not only in the HealthLink environment, but in any environment. I think that as humans, we get so used to technology that we sometimes forget about the fact that, if we can't send an email because email's down, we can actually pick up the phone, or, you can actually write a letter and send it to somebody if it happens to be, personal communication. And that definitely is something that we forget as we become very, very technology dependent. So within the HealthLinks environment, when we are working on the clinical process and design, we specifically, from lessons learned across Ontario just in using the mobile technology, we specifically build backup plans. And they can be as simple as the telephone, but you would be surprised how many people in a moment of panic forget that you can just pick up the phone or that you can include an audio line just in case.
Great. Thank you very much, Sharon. So at this point, I want to thank everybody for their participation in the discussion today, and a warm thank you to our guest panelists for coming and presenting such a rich variety of materials. It's great. Lots of information added to the discussions across the HealthLink tables provincially today. Thank you. Before we close, I did want to remind you of the dates for the remaining webinar, specifically noting a change to the date of the next webinar. The final webinar in our series is regarding maintenance and transitions, and that will take place on Tuesday, November 10th, 2015, as opposed to the original invite, which was the following day. I also want to let you know that you can always connect with the quality improvement specialists who support your LIN region. If you would like more information about the innovative practices, or you have innovative practices you'd like to share and discuss, or resources, we're always open to facilitating this conversation around the province. You'll find their contact information listed here, and we are excited to continue to support the Health Links as they advance. Again, a warm and sincere thank you to our guest panelists and to all who participated today. Thank you very much and have a great day.